Okay, good afternoon, everyone. Welcome to our third virtual shadowing session. Today we have with us Dr. Tulsi Shah, a neurology resident who has put together a very informative presentation for us. Just a quick reminder for everybody that if they have any questions at all during the presentation, you can put it in the chat and we'll go over it after during our Q&A session. Please keep your cameras off and yourselves muted. And also remember that there will be a quiz posted at the end of the session in our Instagram bio, and you need to get a 75 or higher to get credit for this session. That's about it. Dr. Shah, whenever you're ready.
Alrighty, hi everyone. So yeah, my name is Tulsi. I am a first-year neurology resident. So the way that the session is going to work, I'm going to start off with like a little bit of an introduction and kind of walk you guys through my journey to medicine and why I chose neurology. And then today's session, we're going to be focusing on strokes. So I'm going to walk you guys through kind of like a very basic skeleton of strokes, kind of the causes, how to approach a patient who has a stroke and kind of like the workup and management of it. And then we'll go through a case together. So let's see if I can, there we go. So just a little bit about me. I had kind of a untraditional approach to medical school. So my understanding is that this group of students here, you guys are mostly either high school students or undergrad pre-medical students. So for me, I knew pretty early on in high school, actually, that I was interested in pursuing medicine. And I started shadowing as early or volunteering at a hospital like when I was 16 and started shadowing. I found like a local physician who was willing to have me kind of shadow and learn a little bit about medicine. And then kind of going into towards like the end of high school, I decided that I was really certain I wanted to do medical school. And so I actually found like a guaranteed medical program, which I don't know if people are familiar with that, but essentially you're kind of applying into medical school out of high school. And you have like a guaranteed spot into medical school as long as you maintain certain GPA requirements and get certain MCAT score. They're pretty competitive programs. There are several throughout the country, and I was lucky enough to be accepted into one of those programs. And so I did 4 years of college. I wasn't like accelerated by any means. So I did 4 years of college, went to the same medical school for 4 years. And then I kind of stumbled upon neurology. So before I kind of go into the neurology part, just briefly, I was on the admissions committee for medical school last year, my last year of medical school. And so I just wanted to talk to you guys a little bit about things to know and how to stand out as an applicant, because I think that's something that people really, medicine is a very challenging field and it's becoming more and more competitive every year. So people have questions about this all the time. So of course, your grades, GPA, MCAT, all of that is very important. But there's a lot of other categories that is also emphasized a lot in your application. So I think of it as kind of different pools that you want to make sure you're meeting the criteria of. So the first thing is medical experience. So this can be paid or unpaid experience. And that would include things like shadowing. That's very important to have some kind of direct patient care. So whether you're like doing shadowing, if you're like a medical assistant and directly working with patients, whether you are, work with like the EMS, or like scribing, any kind of direct patient care, whether it's you're actually working and doing something, or even if you're just observing, counts in that category. The second thing is volunteering. And so this is non-clinical volunteering. So helping out in your community, doing some kind of community service. So even if you're doing like volunteering at a soup kitchen or working for Habitat for Humanity, some kind of community involvement and volunteering is really important. That's not clinical. So they see that you are also an engaged member of the community. The next thing is leadership. So having, any kind of leadership, whether it's, being an officer at a like school organization, or even if you're just like a tutor, just some kind of position where you're serving as a leader. Even if you play a sport and you're like captain of the sports team, anything like that, it just shows that you have leadership and you can work well with other people and communicate well with others. And then those are like the main three things. If you have research, that's an added bonus, but it's not required. And the research doesn't have to be anything intricate, like anything that you do. Most colleges have like poster symposiums just within their own college, and just presenting your research, even if you're not like doing a full publication or anything, that also looks good on your application. And then, of course, there's a personal statement, a letter of recommendation. So early on when you're in college, I would say think about like science professors, at least like 2 science professors who could write you a good letter of recommendation. And in order to, when you're in the college environment, it's hard to get to know a professor very well. So if there's office hours or things like that, take advantage of that so that you can get to know these professors one-on-one and build a relationship with them come time to ask them for a letter of recommendation. And then you also would want a letter of recommendation from a physician that you worked with. So whether it was in the shadowing capacity or however you worked with the physician, if you're applying to DO school, it is important to keep in mind that they usually require a DO physician as well to write you a letter of recommendation. So make sure you kind of have both the MD and DO physician. And then your personal statement. So, just like it sounds like, you want to make it very personal to you, tell your story. And honestly, I think the more unique, the better. I've read personal statements of all different sorts, and it's really interesting to kind of see what background somebody comes from. So I do think that's an important piece of your application as well. So just kind of making sure that you fill all the different parts, and you don't just focus on grades and the MCAT. You have to be very well-rounded. So kind of talking a little bit about how I stumbled upon neurology as a specialty. So in medical school, your first 2 years is didactics training. So that's all just like learning through textbooks and PowerPoints and just like lectures. And then your third and fourth year is all clinical based. So our third year, we do rotations and a bunch of core specialties. And then fourth year is more getting geared towards applying for residency. And then you do more rotations that are kind of in your core specialty that you're interested in. So my third year, I actually had never considered neurology as a specialty. And my third year, I did a neurology rotation, and I was really fascinated. And I didn't think I would actually consider it as a career until I rotated in it. So I think it's really important to be very open-minded. I thought I wanted to do pediatrics or OBGYN, both of which are very, very different from neurology. But so basically just, be open-minded. The reason why I love neurology, one, I think the brain is one of the most intricate organs in our body, and it's just so intriguing. There's just so much we know, but so much we also don't know about the brain. And I just love that there's always this challenging aspect, and you're also always learning something new. I think it is the only specialty in which we rely so heavily on your history and physical examination skills. Basically most neurologic diagnoses are made really clinically based on their exam, which you'll see when we talk about strokes, why that's so relevant. So I think that was really interesting, because your first 2 years of medical school, even your third year, you're learning all about history and physical exams. And I feel like in stroke, you really do use that skill quite a bit. It is a very quickly advancing field. The number of medications coming out every year is crazy. We're able to treat so much more than we used to. I think when people think of neurology, they think of like very archaic neurology, when like those old stereotypical guys with bow ties, with the little briefcase, like walking around with all their tools. And there's not like, I think very many years ago, or even maybe like 20 years ago, there wasn't a lot you could do for patients with these brain disorders. And we've just come such a long way, and it's advancing so quickly. So I love that about it. Lots of gadgets and technology in neurology. So like the DBS, deep brain stimulation, is a new thing that's really interesting. VNS is like a vagus nerve stimulator. All of these are new therapies that are coming out for different neurologic conditions that are helping patients tremendously. So it's really cool to also be involved in that aspect. The lifestyle is really great. There's depends on what you do within neurology, but I would say like 80% of neurology is outpatient. So mostly like clinic life. And if you want to do inpatient and be more involved and do more hours, you always have the opportunity to. But if lifestyle is important to you and you just want to work like a 9-to-5 clinic job, that's definitely an option within neurology. And then there's so many fellowship opportunities. So, there's stroke, there's headache, there's movement disorders, neuroimmunology. You can do interventional neurology. So that would be like even further subspecialized within strokes. And so many more. Like I just listed like 5 or 6, but there's probably over 10 different fellowships. So you can definitely be like a super specialized. Also, the one thing that's unique about neurology is you don't have to do, like, if you're doing like cardiology, for example, you have to do 3 years of internal medicine residency, and then you do a 3-year cardiology fellowship. With neurology, it's really nice because you only do a 4-year residency. So the first year is internal medicine and the last 3 years is neurology. So it's very, it's 4 years altogether. So it's like a pretty accelerated, it's kind of seems like an accelerated program. So that's really nice. Okay, so now let's go ahead and talk about stroke. So like I said, this is very, very dumbed down, a very skeletal level of strokes. There's people who do fellowships for 2 years about stroke. So there's just so much to learn. But I was just trying to put it together in a quick lecture just to kind of get a basic understanding of what strokes are. So first of all, what exactly is a stroke, right? So you hear about it, maybe you've seen relatives that have had strokes, or you've heard like, oh yeah, if there's like a facial droop, or if you're feeling weak, make sure that, you go to the emergency room right away so that this person isn't having a stroke. But like, what exactly is it? So the way I think about it is it's kind of like having a heart attack of your brain. So when you have a heart attack, you basically have decreased blood flow to your heart. And so your heart is basically like in a stunned state. So that's kind of how it is with the brain. There's different kinds of strokes, but essentially there's some kind of occlusion or something that's some kind of blockage that's preventing blood flow from going distally and perfusing to that part of the brain. And so the part of the brain that's not getting the blood flow, it's not getting oxygen, it's not getting the nutrients it needs. And that area is at risk of being damaged and dying. And so when you see a stroke, or when you see people with symptoms of a stroke, what you're seeing is what effects a person would have if that part of their brain is not being well perfused. So in this image, you can kind of see, it's a very basic image, but just shows that, if you have a blood clot or some kind of obstruction that's not letting blood flow distally from here, the rest of that part of the brain is going to be damaged. So there's 2 main types of strokes. You have ischemic strokes and you have hemorrhagic strokes. So an ischemic stroke is basically when you have an infarct. So that's when you actually have some kind of blockage or occlusion in the vasculature of the brain. So for example, if we're just thinking of like daily, things that you see every day, if you have like a hose, like a water hose, right? And let's say you stick your finger in the water hose, right? The flow of that water is gonna decrease. And if you completely block it, there's gonna be no water coming out. So that's kind of how I think about it, right? So you have some kind of occlusion. Usually it's like plaque or from like high cholesterol, or it's a blood clot that's blocking that vessel, blocking that hose, and not letting flow go distally. So that's in this image here, we can see there's a blood clot and there's no flow out into this part of the brain. So that would be like an ischemic stroke. And then for a hemorrhagic stroke, that's basically when you have blood, like bleeding into your brain. So it can be into your parenchyma, which is like kind of in the deeper parts of the brain, or it could be into the ventricles, which is kind of the spaces within the brain. But similarly, if you have bleeding into your brain, that part of your brain is compromised, and it causes damage of the brain. So here you can see that, there's blood that's pooling in this part of the brain and causing damage into this tissue. And the ratio of infarcts or like ischemic to hemorrhagic strokes is 4:1. So typically we see ischemic strokes much more than hemorrhagic strokes. All right, so for now going into the causes of ischemic strokes. So there's different causes for both ischemic and hemorrhagic. So ischemic, again, remember that's like when you have an occlusion of the actual vasculature or actual arteries or vessels in your brain. And so there's five main classifications. This is a well-studied thing that most neurologists know. It's called the TOS classification. So the first thing is large artery atherosclerosis. So what atherosclerosis is basically when you have high cholesterol and you have the development of plaque. And so I won't go too much into the intricacies, but there's an embolus or a thrombus, but essentially a large artery. So for example, the middle cerebral artery of your brain is one of the biggest arteries in your brain, or even like your common carotid artery in your heart, which is causing there's some kind of plaque that gets flicked off into the brain and causes occlusion and decrease in distal blood flow. So that's the first possibility. The second second possibility is cardioembolism. So that is when you have the source is from the heart. So for example, there is a heart rhythm called atrial fibrillation. And what that is your heart isn't beating synchronously, it's beating asynchronously. So when that happens, there is a higher risk of developing clots, and then those clots can be dislodged and go up into your brain. And then because it's dislodged, it causes decreased blood flow into that part. So cardioembolism is another possibility. Then we have small vessel occlusion. So that frequently happens with patients who have high blood pressure. We call these lacunar infarcts, and it affects a certain part of your brain, more of like the deep brain structure. So like your basal ganglia, the deep white cortical matter, and like the pons, for example. So lacunar infarcts. And then strokes of other determined etiology. So this would be, for example, if a patient has something called vasculitis, which is inflammation of your blood vessels that makes you at more risk of getting strokes, or if you are hypercoagulable for any reason. And what that means is if you have hypercoagulability, that means that your blood is thicker and it's at a higher risk of clotting. So for example, people who have cancer, we call it hypercoagulability of malignancy. People with cancer have a higher risk of having strokes because their blood is thicker and more prone to clotting. And we actually see that a lot with COVID now too. The risk of strokes has gone up with that. And we think that that's also because of hypercoagulability. And then the last thing is stroke of undetermined etiology. So this is when we do a full stroke workup and we're not sure what the etiology of the stroke is. So we call it cryptogenic. So that's for our ischemic strokes. Remember, that's occlusion of the artery because of some clot or some kind of plaque disruption. And then now talking a little bit about hemorrhagic strokes. So there's two main types of hemorrhagic strokes. We have intracerebral hemorrhages, which is bleeding into the actual cerebrum, like the main part of your brain, and then subarachnoid hemorrhage, which is just a different space in your brain, which is kind of like the space that encompasses the brain. And I'll show you in this picture in a second. So for intracerebral hemorrhage, there's many causes, but some of the more common causes, one is high blood pressure. So that definitely increases your risk a lot of having bleeds. The second thing is amyloid angiopathy. So this is something we see very commonly in our elderly patients. So in the elderly folks, you have, especially patients with dementia, they have something called amyloid that it's like a type of plaque that develops in your brain. And because if you have a lot of amyloid, it makes you more prone to bleeding. So you have a lot of different bleeds. So if you look at this image here, this is an MRI image, and it's a particular sequence called the SWI, which is really sensitive for looking at bleeds. And so whenever you see black on the SWI, that is characteristic of bleed. So here you see there's so many different black circles, all kind of in the outside area, which is like your cerebrum. And this is very classic for what we would see in a patient with amyloid angiopathy. So a lot of different, this is what we call microhemorrhages in the outside of the brain. So that is classic for amyloid angiopathy. And so this is something we see in a lot of older patients who have strokes. And then illicit drug use. So cocaine and amphetamines specifically are vasoactive drugs. So they have been associated with a higher risk of bleeds as well. And then for subarachnoid hemorrhages, we could have a rupture of an aneurysm. That's the most likely cause. So if you look at this picture here, an aneurysm is basically like an outpouching of a blood vessel. And so when this thing ruptures or bursts, then there's just bleeding that can go basically into your brain. So here you can see, you can see that there's an aneurysm here, and if this were to burst, there's a bunch of bleeding that pools around here, and because this area is not getting blood flow, then here you're having a stroke or you're having damaged blood tissue. And then you can also get subarachnoid hemorrhages from vascular malformations. So that's usually something that's more like genetic. So that's hemorrhagic strokes. So what do these patients present with? Like how do they present? Like, how do we know they're having a stroke? So you might recognize this diagram or something, have seen something similar. A common mnemonic that people use is FAST. And so that's just to know or like to spot a stroke. So it stands for face, like a facial droop. A is for arm weakness and even leg weakness. S is for speech difficulty, so either slurred speech or difficulty producing speech or understanding. And then T is for time, because stroke is a very time sensitive thing, just like a heart attack, which you'll learn in a second. So these are like the things to kind of look out for, but the presentation really varies quite a bit based on the type of stroke you have, whether it's hemorrhagic or ischemic, and then also how big the stroke is, what particular area of the brain it's in. And that's kind of what I was referring to earlier with like the physical exam. Based on what symptoms a patient has and what their exam looks like, even without an actual image, we can kind of figure out what part of the brain is affected just by the way that they're presenting, which I think is so interesting. So that's one thing. And then the presentation is very acute. So basically they're completely fine, and then all of a sudden these symptoms start. So very acute onset. And then something like more specifically for hemorrhagic strokes. So typically the subarachnoid hemorrhages, they bleed quicker than intraparenchymal hemorrhages. So for subarachnoid hemorrhages, kind of like the classic board question that we get is, it's a sudden onset, like the worst headache of my life. That's usually how patients describe it. And so whenever that's the case, you definitely want to rule out any like subarachnoid hemorrhage. And then you would also see other signs of increased intracranial pressure, because if you think about it, there's a bleed that's happening really, really quickly in your brain, and in that surrounding area, you have increased intracranial pressure. And so because of that swelling, you're getting a huge, terrible headache. And then also, a lot of these patients have nausea and vomiting because of that increased pressure in their brain. And then intraparenchymal hemorrhages, the symptoms are pretty similar, but maybe an earlier change in consciousness, and then nausea, vomiting, headache, kind of similar to subarachnoid hemorrhage, but the onset might be a little bit slower and not as severe. So now kind of going into diagnostics and kind of how we triage and see these patients. So I'll go more into kind of like a flow sheet in the next slide where I talk a little bit about how we systematically approach this, but just the imaging that we typically do. So in the acute setting, when a patient comes in for a stroke, the first thing we always do is we get a CT head, non-contrast, a CTA, and a CTP. So CTA is CT angiogram and CTP is CT perfusion. And in a couple minutes, I'll kind of go over why those three are really important, specifically in the acute setting. And then the other imaging we do is more so to determine what the etiology of the stroke is. So we went over the different causes for ischemic strokes and for hemorrhagic strokes. And it's important for us to figure out what is causing the stroke so we can target treatment according to the etiology. So for these things, it's helpful to get a transthoracic echocardiogram. So that's basically an ultrasound of the heart. Which can be helpful for seeing if there is a cardioembolic cause of stroke. So for example, I was talking about that heart rhythm. With that heart rhythm, there's certain things you might see, like your left atrium might be a little bit enlarged, or you can actually see a clot in the atrium, things like that. A carotid ultrasound can be helpful to get good imaging of the vessels. That's usually for patients who aren't able to tolerate contrast for any reason. If there's anybody who's like allergic to contrast, or they have really severe kidney disease and can't get contrast, we would do carotid ultrasounds, but typically we choose to do a CT angiogram or an MR angiogram because that gives us really good imaging for the vasculature in your neck and in your brain. And then for all patients, we get an MRI of the brain because that's like the most sensitive and specific, as well as an MRA. And then everybody gets a lipid panel and A1C. So a lipid panel will tell you like the cholesterol, and then the A1C will tell you if this patient has diabetes or is at risk of diabetes. So now kind of talking about the flow of when a patient comes in with a stroke. So I have two different flow sheets here. They're a little bit different, but we can kind of go through them. So a patient comes in with a stroke, and so what happens, right? Like, so first of all, typically the patient will call 911, and based on the symptoms, we already probably know that there's a stroke that's coming in. Usually EMS that first responds to them, they will let the emergency room know because it's so time sensitive that there's a stroke coming in, and we, the neurology team, will be notified. It depends on the hospital. All of this is very dependent on the hospital, but typically it's kind of the same way. So, and I'll kind of talk about this. This will all make a little bit more sense when I go through the case as well, but the time onset, so we want to make sure that patients are within 3 hours, 3 to 4.5 hours. So there's like an extended window now for a particular treatment called TPA, which I'll go into in a second. And so for that particular treatment, you have to be between 3 to 4.5 hours, or not between 3 to 4.5 hours. You have to be within 4.5 hours since the onset of symptoms or since the last known normal. And so basically, the patient comes in, the emergency physician will evaluate to see if this patient seems to meet the criteria of a stroke. And if so, we'll immediately activate a stroke code, which every hospital has. When a stroke code is called, a lot of these things are kind of happening simultaneously. But first, the neurology is notified when there's a stroke code, the neurologist. There's a stroke nurse team at most hospitals, so they're immediately notified as well. And so they come in and they do blood tests. So they collect blood, they check the glucose. And the reason for that is sometimes if your glucose is low, it can mimic a stroke. So we want to make sure that, is this just hypoglycemia or is this actually a stroke? And then an EKG, which will tell you the heart rhythm to determine if, what the patient's heart rhythm is when they come in. Like, let's say they're in atrial fibrillation, then that tells us that maybe this patient is having a stroke and that might be the cause. At the same time, the neurology team is there and we are assessing the patient. We're getting a history as quickly as possible from the patient if the patient is able to produce speech and talk to us. If not, we try to contact a family member right away so we can get more information, because it's so important to know when the patient's symptoms started and when they were last seen normal, because we use that time as a calculation of whether the patient is a candidate for TPA. And then usually this is all happening at the same time we're wheeling the patient down to the CT room. So, the nurse is collecting blood, we're trying to wheel the patient down, and I would be doing my assessment and doing my exam of the stroke of the patient to see if, what their score is on the NIH stroke scale, which we'll go over in a second too. And so then you get to the CT room, and the first thing you do is you get a CT head without contrast. And I'm going to skip ahead for a second just to show you guys. So the CT head non-contrast is a quick image that there's no contraindications for. So every patient can get it, and that will tell us very quickly if the patient is bleeding or not bleeding. So if there is bleeding on a CT head, you'll see white. So a lot of white, like blood is white on CT head. So if the patient is bleeding, then they're not a candidate for TPA, which is like a clot busting medication. So that's something we need to know right away. So that information will tell us that. At the same time, we get a CT angiogram. So first we do the CT head. We look to see, does this patient look like they're having a stroke? A lot of the times, the CT head might look completely normal because it can take some time to see those changes in your brain on a CT. But if there's bleeding, that is something that we can immediately see on a CT head. So let's say the CT head looks normal, we don't see any bleeding, then we proceed with the CT angiogram. So what this is, and this is for most patients, as long as they don't have any contraindications, because CT angiograms require contrast. So some patients might have allergies, but it's really important to find out what the allergy is, because sometimes like a patient might just have, maybe they'll just like have like a rash or something, or maybe they'll feel not like, like they'll have nausea or something, which isn't really a huge contraindication. But if they have an allergy that's like anaphylaxis, where their throat swells up and they're not able to breathe, that's a severe enough allergy for us to not give the contrast. So a CT angiogram, and that is going to help tell us if there's a large vessel occlusion. So is there a big artery that has severe blockage? And that would kind of that would be helpful for the next part of treatment. So there's TPA, which is a clot busting medication, and there's thrombectomy, which is an actual procedure in which you basically go in to the blood vessel that has the clot, and you manually dislodge the clot, or like take it out. So if there's a large vessel occlusion, then the patient is a candidate for thrombectomy. And then the last image is the CT perfusion. And this image will tell you what tissue is infarcted, so which tissue is already damaged and what tissue is salvageable, so which we call the penumbra. So what tissue is at risk of being damaged but isn't damaged yet? So what can we still save? So that's really important too, because we don't want to go and do a procedure, because with any procedure, there's a risk as well. If the patient already has what we call no mismatch, so like they have a large core infarct and they don't have much of a penumbra, which means there's not much of a mismatch. The area that's supposed to be damaged is already damaged. If we go in there, we're not going to help save any further tissue. So that's super important. So kind of going back to this flow chart, so we check the CT head. If there is a hemorrhage, there is bleeding, then we consult neurosurgery. And I'm not going to talk too much today about hemorrhagic strokes. That's like a whole different lecture. But basically with hemorrhagic strokes, a neurosurgeon will decide if the bleed is big enough to go to the operating room and to do like a partial craniectomy, where they take out part of the skull to evacuate the blood and allow for your brain to swell and expand. And then sometimes they can do a procedure where they kind of put in like a drain into the brain to allow for all that extra blood to kind of drain out. So that's what would happen if there was a hemorrhage. If there's no hemorrhage, then we're trying to figure out, is this patient a candidate for TPA? So TPA stands for tissue platelet or tissue plasminogen activator. So the other name for it, like the generic name, is alteplase, and essentially what it is, it's a clot busting medication. So if you have an ischemic stroke, remember there's some kind of obstruction to the blood flow, right? So we want to see if we can break that clot up. And so that the TPA, it's an IV medication that goes, and it kind of, the goal is, it's like a really strong blood thinner basically, and it just breaks up all the clots that are there. But there are contraindications to that. So we want to make sure first, talk to a family member or talk to the patient to make sure they don't have any contraindications that would put them at higher risk of having that would put them at higher risks of having complications from TPA. And the biggest thing, biggest complication of TPA is having hemorrhage or hemorrhagic conversion. So basically, because it's a clot buster medication, it also makes you at a higher risk of bleeding. So we want to decrease the risk of bleeding. If this patient already has an ischemic stroke, we don't want them to start bleeding into their brain as well. So that's kind of the biggest complication or risk of having a TPA. So we determine if they're a candidate for TPA. If no, we kind of do a standard stroke care. If they are, then we would proceed and give them TPA as soon as possible. And this chart kind of isn't too different, but just shows that basically everything's happening simultaneously. So we're evaluating if they're a candidate for TPA, what window they're in, if they're less than 3 hours, between 3 to 4.5 hours, and then also evaluating if they're a candidate for thrombectomy. For thrombectomy, the window is 12 hours, but there is an extended window of up to 24 hours when the patient can get a thrombectomy. But really, time is money for a stroke. So the sooner you do everything, the better the outcome. So we really try to get things done as soon as possible. So we talked about this imaging. So the biggest thing for strokes is controlling the risk factors. So blood pressure is a really big, blood pressure control is huge for stroke. It's probably the biggest thing you can do for stroke. So the criteria for blood pressure is after an acute stroke, the first 24 hours, you want to allow for the brain to get perfusion. So it's called permissive hypertension. And what that means is we allow the patient's blood pressure to run high, because if you think about it, there is basically there is something that is obstructing blood flow, right? There's a clot that's stopping blood flow from going to the rest of the brain. And so we want the blood pressure to be higher because we want to allow for the rest of that damaged brain to get as much blood flow as possible to try to save that area. So the first 24 hours, we actually allow the blood pressure to run pretty high, with the systolic blood pressure can run up as high as 220 to allow for, we don't increase the blood pressure, but if the patient's blood pressure is high, we allow it, we don't treat it. And then, long-term as well, it's important to have good blood pressure control, but just in the acute setting, we want the patient's blood pressure to be higher to allow for more perfusion of the brain. The other thing is lipid control. So that is basically controlling your cholesterol. So it really does depend on the etiology of the stroke, but if somebody has high cholesterol, they have a lot of plaque in their arteries, the plaque is at risk of being dislodged and causing a stroke. So we really want to lower that person's cholesterol, and we do that with certain medications, which I'll go over in a second. And then hyperglycemia, so just high sugar. Patients with diabetes are at higher risk. So the main risk factors for stroke is high blood pressure or hypertension, diabetes, high cholesterol, and smoking. So these are the 4 things we really want to target to prevent strokes from happening in the future. So, targeting the glucose in the hospital setting, we want the blood glucose to be between 140 and 180, a little bit higher than we would in an outpatient setting, but we want to make sure that the sugar is well controlled. And then lifestyle modification. So like I said, smoking is a huge risk factor for stroke. So, counseling the patient on stopping with like smoking cessation. For certain populations that are using cocaine or amphetamines, that's also a very it's a vasoactive drugs, so it puts you at higher risk of stroke. So advising patients to stop that, and then just diet, exercise, and just lifestyle modifications in general. So talking about secondary prevention, so what drugs do we use to prevent strokes from happening in the future? So the first class of drugs is called a statin, and this is targeting the high cholesterol. So there's a bunch of different statins. There's atorvastatin, rosuvastatin, pravastatin. There's a whole class of drugs, but this helps in prevention or to decrease the cholesterol to help prevent strokes. Then we have antiplatelets, which prevents which prevents the platelets from clumping together and forming clots, which would make you at higher risk of stroke. So the common one that we all probably are familiar with is aspirin. So basically every patient with a stroke is on aspirin for life. And then anticoagulation. And this one is something that not everybody gets. It's really dependent on the etiology of your stroke, but anticoagulation is a blood thinner. So for a patient who has, for example, a higher risk of clotting, like I had said earlier, people who are hypercoagulable, people who have thicker blood because maybe they have cancer, or for some reason, maybe genetically they have a higher prevalence of getting blood clots. These people we want to put on blood thinners to lower that risk. So this is kind of how we treat with medications for secondary prevention of strokes. So now I'm just going to go into one case just to kind of tie all the pieces together. So this first case, we have an 85-year-old female. She has history of hypertension, so that's high blood pressure, hyperlipidemia, which is high cholesterol, and neuropathy. And she's coming in with sudden onset aphasia, which is a word that basically means you're having difficulty either producing speech or understanding speech, as well as a facial droop and right-sided weakness. So you talk to this patient's husband to get more of a history because she's aphasic and not able to talk or give you a history. And he tells you, she was completely fine. She was doing okay. They had gone out to dinner, came home, and she was on the phone, had just hung up on the phone and just had mentioned that she was feeling tired, wasn't feeling too well, and that she wanted to just sit down on the couch and rest. So he tells you that around 18:30, so around 6:30 p.m., that's when she got off the phone. She was completely normal. He didn't notice anything wrong, but she just had mentioned that she didn't feel so well. About 10 minutes later at 18:40, her husband went to go check up on her and noticed that she was basically not waking up. He called 911. EMS arrived about 20 minutes later at 1900, so around 7 p.m. And at that point, she had woken up a little bit. She was more alert. She was arousable, so you could kind of wake her up. But she was nonverbal, so she couldn't talk, and she was not following any commands. So if you asked her to, let's say, like, give me a thumbs up, or there's different, and that's a whole nother topic, but like different ways to assess how much a patient understands, all part of our examination skills. So the patient is not able to follow any of your commands. By the time she arrives to the hospital, it's 2000, so 8 p.m. So if you think about it, her last known normal was at 6:30 p.m. And at 8 p.m., she arrives to the hospital. So it's been an hour and a half. So she's still within our 3 to 4.5 hour window to get TPA. And something I forgot to mention, a contraindication of TPA is if the patient is on a blood thinner, because if you think about it, TPA is a clot busting medication, right? So it kind of thins out your blood and breaks up clots. If somebody's on a blood thinner already, then that's going to make you at a much higher risk of bleeding if you also give them TPA. So this patient, let's just say she is not on a blood thinner. So the first step is to evaluate our patient. So a stroke code is called and we go to assess the patient. So I had mentioned the NIH stroke scale earlier, and I have that up here. And I'm not going to go through all of it, but this is just kind of for reference. We use this to kind of score the patient and see how bad their stroke really is. So this patient scored a 13. And the reason she scored these points was because she was aphasic, so she couldn't talk. She wasn't following commands, and she had decreased sensation on her right side. She had drift on her right side, which is basically shows like a subtle sign of weakness. And then she also had a facial droop. So with all of this being factored in, her stroke scale was a 13. The other important things on arrival, her blood pressure was 183/60. Her glucose was 116, so she was not hypoglycemic. Her INR, which is a number that kind of tells you how thick or thin your blood is. So if a patient has a really high INR, it tells you that their blood is really thin and really has a higher risk of just bleeding. Her INR was normal at 1.1. And when she came in, let's just say they put her on telemetry or they got an EKG and she was in a heart rhythm of atrial fibrillation. So she was not in normal sinus. So the second thing we do, remember, we take her right away to imaging. And the first thing is a CT head. So that's going to tell you, remember, if there is blood or no blood. And so here are on our right, and these are images I got from the internet. This isn't for this patient specifically, but I just wanted to kind of show you guys some images. So some imaging early on in a stroke, you can see something called a hyperdense MCA sign, which we see here. So this patient is having a left MCA stroke, and on brain imaging, it's kind of the opposite. Like this looks like, for us, it's on our right, but for the patient, it's on the left. So you can see that there's this part right here is bright, and it's called the left MCA sign. The MCA is one of the bigger large vessels. So, we were talking about large vessel occlusions earlier. The MCA is a large vessel. So this part with our hyperdense left MCA sign, that tells us that this patient probably is having a left MCA stroke. That along with kind of the way that she presented. So then we go ahead and get a CTA because she doesn't have any contraindications to contrast. And if we look at our CTA, this imaging is very helpful for us to see all the vessels in the brain and in the neck as well. So here, if you look at it, we kind of look for asymmetry because that tells us that something is off. So this is kind of our biggest vessels. This is our MCA. And if we look at the right MCA right here, you can see if you can actually follow all the blood flow all distally up to the, pretty distally into the brain. If you look on our left side here, you have your MCA here. This is what we call a cutoff because you see that you're not getting that same perfusion into the other parts of your brain. And pretty early on, you have this cutoff. And there's different territories, and I'm not going to go into it, but basically this is an M1 cutoff. So that's our CTA. Our next thing is the CT perfusion. So the CT perfusion, remember, we're comparing our core infarct versus our penumbra. So if you look at this image down here, the purple part here tells you how much of your brain tissue is already damaged. So the purple part here, you can see that this is in the territory of your MCA. This part is already damaged. The green part tells you how much of the brain is at risk of being damaged, but is still not completely gone. So you still can save that territory. So here, your penumbra is quite a lot, right? So there's a mismatch here, and there's certain numbers, and I'm not going to go into the intricacies, but there's certain numbers that we look at to determine if they have a large enough mismatch. And this patient did have a large mismatch, which means that they are a candidate for thrombectomy. So now going into acute management for this patient. So because she was within that window of 3 hours, or the extended window of 4.5 hours, she was able to get TPA. She didn't have any contraindications. After she got TPA, she was transferred to a tertiary care center. So at that point, she was actually transferred to our hospital, and she ended up getting a thrombectomy because she had that large vessel occlusion. And then we did do a CT head again. And when she arrived, we did a CT head. So sorry, I forgot. So the CT head was before we went ahead and did thrombectomy. And the reason was she had gotten TPA at the other hospital. And like I said, you have a high risk of bleeding after that. So we wanted to make sure she didn't develop a bleed after she got TPA. So the CT head after didn't show any bleeding. So she was able to go for thrombectomy. And they were able to see the clot in thrombectomy and take out that clot, and basically had a reperfusion of TK3. So basically there's a different scoring system that tells you if the brain, how well perfused the brain is after the clot is taken out. This is just a scoring if anybody is curious, but a TK3 is like basically a really good score. So then other diagnostic imaging we did later on in her hospitalization. So we did an MRI of her brain, and it showed an acute left MCA infarct. So this is like the area of the brain that you can see was damaged because of the stroke. We got a TTE, which is the ultrasound of the heart. It showed the ejection fractions, that's how well your heart is pumping, was normal. It didn't show a patent foramen ovale, which is basically a hole in your heart that puts you at a higher risk of having strokes. So she didn't have that. And her left atrial size was 2.8 centimeters, which was normal. Her A1C, which tells us about if the patient has diabetes, was 6.2, so that's in the normal range. Her LDL was 62, which is actually pretty good. So her cholesterol is not that high. We look at LDL, which is kind of your bad cholesterol, and we want it to be less than 70. So she actually met that criteria. So now in terms of management and treatment, so first we want to determine what the etiology of the stroke is. So remember I had mentioned this patient had come in with atrial fibrillation. So she had that weird heart rhythm in the beginning. So we determined that her etiology was cardioembolic from this abnormal heart rhythm. For secondary prevention, she was started on atorvastatin, which is the type of statin that helps with lowering your cholesterol. Her dose wasn't as high because her lipids were already well controlled. And then we started her on an antiplatelet because we do that for all ischemic stroke patients. So that was 81 milligrams. And for her, we did start her on anticoagulation because her etiology was cardioembolic. And for cardioembolic patients, they do have a higher risk of clotting. So we want to thin their blood out to prevent that risk. So she was started on a particular anticoagulation called apixaban, 5 milligrams twice a day. Then the other things we want to think about is treating her atrial fibrillation. So that's that abnormal heart rhythm. So she was put on a couple of medications that helps with that heart rhythm and at least decreasing the rate, which I'm not going to really go into too much. And then for her high blood pressure, that was treated with another medication as well. And then the last thing for strokes is physical therapy and occupational therapy, which is actually a very important part of stroke care. So after we kind of treat the patient with medications and preventing strokes in the future, the patient needs to get better. And the weakness just doesn't go away overnight. It takes a lot of time, and the patients usually have to go through a lot of rehab before they can recover, and they might not recover at all. Most patients actually don't get full recovery of function, but for best outcomes, they do need to go to rehab. So the physical therapy and occupational therapy team in the hospital comes and sees the patient, and they evaluate which kind of rehab care the patient needs. And for this patient, they recommended an acute rehab facility. And that's kind of how we manage and treat strokes. So that's what we did for this particular patient. And she was discharged from the hospital, and she was kind of she got most of her speech back, not completely, which hopefully with, speech therapy and practice and rehabilitation, she can go ahead and get that back and get some of her weakness back, regain some of the weakness that she had acquired. So yeah, that's kind of a very, very general, very simplified form of kind of what strokes are, the management of strokes. Yeah, at this time, I can go ahead and answer any questions. And if you guys have any questions that you think of later on, I left my Instagram handle on here, and you can feel free to DM me or reach out to me if you have any other questions.
Thank you for that very informative presentation. If anybody does have any questions, please put them in the chat, whether it's in the Zoom chat or the YouTube live chat. I did have one question.
Sure.
So you mentioned that you went to a direct med program, right?
Yeah.
Where was that? With which school?
VCU. It's in Virginia.
Yeah. So it was a BSMD program, right?
Yeah, a BSMD program. That's correct.
Another one is, so is there anything that you know now that you would have wanted to know, like when applying to schools?
Yeah, I guess one thing I would say is, I chose to pursue medicine at a very early stage in my life. And I think there's so many different avenues to pursue healthcare now. And I think, when I was young, I was a little bit naive and didn't really know all the options. So I would say for anybody who's interested in the medical field, really make sure you take the time to look at everything, explore all your options. Don't be like completely set on just being a doctor. Like you can still have a huge impact on patient care or public health or just healthcare in general, doing so many different, like through so many different avenues. You can be a nurse practitioner or a physical assistant, or sorry, physician assistant, or you can do physical therapy and occupational therapy, or like speech pathology, or there's just so many different avenues within healthcare now that I wasn't aware of when I kind of had chosen to pursue medicine. So I would definitely say take the time to explore all your options and get exposure to all the fields you're interested in before deciding on what you want to do.
Yeah, going off of that, so I know that exposure is really important, but because of COVID, it's also pretty hard to get that exposure right now. What would you suggest?
Yeah, I know. I've had a lot of people ask me that, and it's really unfortunate that you guys don't have the opportunities to like go into a hospital setting and volunteer and stuff like that. I know, just like you have this Instagram page, I know there's a lot of other people who are doing similar things where they're having like different, doctors come and kind of talk about their field. And unfortunately, it's really hard to get any better exposure at this point. Hopefully, by the end of this year, there's more opportunities, and with the vaccine coming out and more people getting vaccinated, you'll have that opportunity again, because it's really hard to get that same clinical exposure if you're not in that clinical setting. And I think a lot of medical students, I think they got hit the hardest, like third-year medical students who are supposed to be doing rotations this year, because especially like the first half of the year, everything was virtual. And I just really don't think you can learn that way. You have to see patients and take care of them and see those physical exams and practice that in order to be, to learn that skill. So hopefully with time, you guys are able to, really be in that setting and take advantage of that.
Okay, so I don't see any questions in the chat, and I am out of questions. So if nobody has any more, I guess we can conclude this meeting. Thank you all so much for coming. And yeah, Shashwat, you can end the